Welcome to today's CFN webinar. Today's session is Talk to Me, Seriously Ill Patients' View on Physician Behaviors that Influence the Quality of End-of-Life Communication. Just so you know, the webinars and slides are posted on the website, and you can see that on the slide in front of you. It should be there in about 48 hours, and it will have the webinar as well as the slides. Okay. And we will be doing a question and answer session. The webinar will likely take about 35 minutes. We'll try to get to all of your questions. Please use the submit your question functionality on GoToWebinar, and we'll try to get to as many as possible. And if we can't get to them all, we'll see if there's a way to facilitate answering the questions in another way. Today's presenter is Dr. John Yu, and he's a hospital-based general internist who is a staff physician with Hamilton Health Sciences. He's the associate professor in the Department of Medicine and of Clinical Epidemiology and Biostatics at McMaster University. He's a member of Clarity Research Group at McMaster, and he's the executive member of CareNet. So over to you, John.
Great. Can everybody hear me?
Yes.
I hope so. Great. I just have to bring up my slides. So can you guys see my slides on your end?
Yes, I can see them.
Is that good? I've got it full screen now.
Yeah, perfect. Go ahead. Thanks, John.
Okay. So thanks everyone for attending. The information I was given was that there's at least 100 of you out there, although it looks like there's even more looking at the control panel. So welcome everybody. And thanks to Carol for the introduction. I should start this presentation by thanking a number of people who are listed on this slide. This was a team effort across two sites in Hamilton and Calgary. But the biggest thanks go to Dr. Amani Abdul-Razak. So just for some context, what I'm going to present to you in terms of the study findings are in fact the result of Dr. Abdul-Razak's master's thesis, which was a CFN-funded project. In fact, one of the very first projects funded by CFN several years ago. And so she's a former student of mine, and I have the privilege of presenting this work on her behalf. I think I don't have the objective slide here, so I'll just verbally tell you the three main objectives of this webinar are, in terms of context setting, I'll provide some data about current gaps in end-of-life communication and decision-making with patients who have serious illness. I will describe a Made in Canada conceptual framework that fleshes out what we mean by end-of-life communication and decision-making. What are the different processes involved? And then the meat of the presentation will be a reporting of Amani's study, the Talk to Me study, describing what specific physician behaviors do patients find helpful during end-of-life discussions. So this slide here is just to say that the way we die now in the 21st century is quite a bit different from even just a few generations ago, certainly very different from 100 years ago. And I think for any of you on the line who work in clinical practice settings, I think you would agree with me that most patients nowadays die of, on the trajectories that are shown in the bottom half of this slide, either from relapsing or exacerbations of advancing chronic illness such as heart failure or COPD, cirrhosis, or experience more prolonged and slow deterioration in a state of frailty and a characteristic description here would be, or example here would be a patient with progressive dementia. Whereas 100 years ago, most people died of either a sudden death or a sudden illness. And the data that I'll present today is really derived from hospitalized patients. And I work in a hospital setting, and so this speaks from my experience. Many of our hospitalized patients, in fact, are not hospitalized with acute conditions, but are actually admitted with one of these bottom two conditions. And we also know that in Canada, hospitals continue to be a major provider of end-of-life care, even though we may not, hospitals certainly may not view themselves that way. Over time, perhaps this number will change, but currently 50 to 60% of Canadians will die in a hospital. And of course, there are many more patients in hospital beds who maybe are not going to die that admission, but are nearing the last 1 or 2 years of their lives, who are on these organ failure or frailty trajectories. All this to say that, when we go directly to hospitalized patients who are approaching the end of life, who have serious illness, and ask them what's most important to them in their care at end of life. This is a study by Darren Hyland, one of my colleagues, published in 2006. He surveyed, or the CareNet group surveyed hundreds of patients in hospital and asked them what was most important to them in end-of-life care, and these were the things they rated as most important or extremely important. And I won't read all of these out to you, but a lot of these items, things like having trust and confidence in your doctor and receiving honest information about disease, speak to the need for good end-of-life communication and decision-making. So patients are directly telling us that this is very important in their care at end of life. But they've also, in follow-up studies done by Darren and the CareNet group, they have clearly said that they're not completely satisfied with end-of-life care that they're receiving, and furthermore have identified end-of-life communication and decision-making as one of the areas that's most important to them, but that they're least satisfied with it, identifying communication and decision-making as one of the highest priority areas to improve end-of-life care in Canada. So when I say end-of-life communication and decision-making, what exactly am I talking about? Because different people have different conceptualizations of what that might mean. And so I was involved in a group that pulled together a multidisciplinary expert panel, and through a modified Delphi process and consensus process, we arrived at this conceptual framework of end-of-life communication and decision-making to guide our work in the area, and just to clarify a few terms. And this also resonates with the Speak Up campaign in Canada, the Advanced Care Planning in Canada initiative, housed at the Canadian Hospice Palliative Care Association. And in this framework, advanced care planning on the far left is viewed as, because there's been a lot of talk about advanced care planning and its importance, is viewed as an upstream process earlier in the disease or earlier in the life trajectory. It's a process that focuses primarily on conversations rather than simply documentation. And it's conversations between patients, and in particular with the person who's going to be their substitute decision maker, to talk about values and preferences. What does quality of life mean to me as a person? And making sure the substitute understands that, with the purpose of informing future events where in-the-moment decisions need to be made about treatments, including treatments about different forms of life support, including CPR. And so advanced care planning, in its most contemporary definition, and what the Speak Up folks have emphasized, advanced care planning in and of itself doesn't constitute consent or a hard decision about future treatments, but rather it enables the substitute, or even the patient, him or herself, to be better equipped to make in-the-moment decisions that are grounded in patients' values and preferences. This is important in Canada because legislation that would govern advanced care planning type activities is in fact quite different in different Canadian provinces. And so the legalities of what constitute consent are, for example, quite different in Ontario compared to BC or Alberta. And so by emphasizing advanced care planning as a process that's about conversations and not necessarily about decisions, it helps to make it fit within all the different legislative contexts in Canada. The middle box is just illustrating that there's a concept of goals of care discussions that we've separated. There's, in real life it's a bit similar to advanced care planning, but the distinction here is that once patients actually do experience serious illness, whether it's very advanced heart failure or advanced cancer, then the discussions change in tone. There's a lot more to talk about in terms of the actual illness and patients' understanding and what's the prognosis with this illness, and in that context, what are their fears, what are their values, how much are they willing to put up with to achieve certain outcomes, and all of that information, as well as the good advanced care planning, can inform those future in-the-moment decisions. So that's the context setting. Oh, right, sorry, I had a couple others. I'm going to keep it pretty short because I want to get to Imani's results. Just to say that we've also done work with hospitalized patients in Canada that has documented deficiencies in the quality of these discussions, such that it is leading to a lot of discordance between what patients would prefer in terms of treatment, and that's the stuff in blue. So very few patients would prefer CPR, in fact, when directly asked. But that's in stark contrast to the orders for life support that are in their chart at the time of these interviews. So the bars in red are showing what turns out to be about a 70% discordance between the prescribed orders for CPR and other life support compared to what patients state would be their preferences. So it's highlighting gaps in end-of-life communication with seriously ill patients. And the only other point that I would make is that when we examine this further, that key elements of end-of-life discussions are not discussed by physicians or clinicians with patients. So things like discussing prognosis or asking about values are occurring only 10 or 16% of the time when patients are directly asked. And yet, the more of these items that are discussed, the greater likelihood that there is to be concordance between patients' wishes and their prescribed care plan. So we know that, just to summarize the context, we know that end-of-life discussions are important to patients. We know that they've said they're not satisfied with the current quality. We also know from direct audit data that I just showed you that many of these communication items are not talked about with patients. But what we don't know, so it highlights that it's an important area to address, but what we didn't know much about when Imani set out on doing this work is we kind of know what patients want to discuss with their physicians, but there wasn't as much known about what kind of physician communication behaviors did patients most value when broaching end-of-life conversations. And we thought that this was important information that would inform future strategies to improve the quality of communication around end-of-life issues during serious illness. And so the objective of Dr. Abdul Razak's thesis project, the Talk to Me project, was to understand the perspectives of seriously ill hospitalized patients on the effect of different physician behaviors on perceived quality of end-of-life communication. And the goal was to try to identify some pragmatic strategies or pointers, really, for practicing clinicians to improve their communication around these issues. And so we chose a mixed methods approach to address this question because we thought it was a good fit with the complex nature of end-of-life discussions. So there was a quantitative strand which involved a cross-sectional survey of seriously ill patients in hospitals in Hamilton and Calgary. And we used a validated quality of communication questionnaire for the quantitative strand. It's a validated instrument developed by Randy Curtis and others who are end-of-life researchers in Seattle. And in the qualitative strand, we used an interpretive description approach to do semi-structured interviews to drill down a bit more into what patients found most helpful during end-of-life discussions with their physicians. I'm going to skip over this because I pretty much restated it. So who did we approach exactly? So at these two hospitals in Hamilton and Calgary, we were targeting patients who were at high risk of dying on internal medicine or medical floors. And this is consistent with prior work we've done in this population in hospitals. So individuals who were admitted to hospital and over the age of 80 were eligible. Or patients could be younger, so over the age of 55, but have clinical markers of advanced chronic disease such as CHF or COPD. Or if they didn't meet either of those criteria, if a member of the healthcare team would not be surprised that the patient died in the next year, we could also enroll those patients. Taken together, these criteria identify a group of patients with a mortality of about 50% at 6 months, so it is quite a seriously ill patient population. So this slide is just going to show a schematic of sort of the structure of the patient recruitment and the data collection. So in the quantitative strand, there were a total of 132 patients enrolled across the two sites. We collected demographic information, and we administered this validated quality of communication tool. I'll give you a little bit more information about this instrument when I get to the presentation of those results. In the qualitative strand, we took a purposefully sampled subgroup of 16 patients from this 132 patients who completed the quality of communication tool. And we did the semi-structured qualitative interviews with those patients and analyzed the interview transcripts as well as field notes as a qualitative data set. I won't get too heavily into these details because I'll walk through the actual results at the time. But just to say that then there was a final data merging stage where we compared and contrasted the qualitative and quantitative results as part of the mixed methods approach to learn where there was sort of consonance or dissonance between the two strands of data. So we screened 611 patients at the two sites, but after excluding a number for a number of different reasons, including a large number of patients who endorsed that their physicians had not discussed any kind of end-of-life issues with them, we were left with 152 who were eligible and enrolling 132. So a pretty good participation rate for patients who were deemed eligible. This gives you a description of the 132 patients. So fairly elderly, mean age of 80, many of them having been hospitalized several times in the previous year. I guess importantly, almost all Caucasian, so the extent to which these data generalized to other groups in our diverse Canadian population, I think that's important to keep in mind. So here are the results of the quantitative strand. So just to orient you a little bit to the quality of communication questionnaire, it is an instrument that has 13 items that describe different behaviors in physician communication. Things like, and they're listed here, the 13 items. So things that range from more general communication behaviors like eye contact, item 2, or answering all your questions, item number 3. Whereas the items 7 to 13 are more specific content issues, such as number 8, talking about details about the possibility of getting sicker, so it's kind of prognostication. Or asking about things in life that are important to you, item number 12, so asking about values. And so this is just giving the mean scores in the second column from the left, from the right, for each of these items. The items are rated on a scale of 0 to 10. So 0 being the patient saying the doctor was the very worst I could imagine at performing this particular behavior or addressing this issue, and 10 was the very best I could imagine. So a couple of things to note. First of all, if the patient reported that the physician actually didn't do it, that was interpreted, scored as a 0, and there were in fact a lot of didn't do responses for the items 7 to 13. And so that's obviously lowering the mean score for those items quite a bit. Otherwise, for the first 6 more process types of items, patients were saying that they were, moderately, that the doctor was performing at a moderate quality on a scale of 0 to 10. So the other thing that we did to try to tease out, the main objective was to see, are there particular behaviors that patients find particularly helpful when talking to their physicians? So what we did is there's also a global rating item that's part of the QOC instrument that just asks, overall, how would you rate this doctor's communication with you about the types of care you would want if you became sicker? And the overall mean is here, 7.1 out of 10. But what we did was to look at how well do these individual items, 1 to 13, correlate with the global rating item. So in other words, were some of these behaviors more linked to or more associated with overall satisfaction compared to others. So that's what's shown on this slide and the next slide. So you'll see here the correlation that we looked at was we used a Spearman-Rowe correlation coefficient. And what you see here, especially if you round it to just 1 decimal place, is that all these 6 kind of behavior items, whether it's eye contact or listening or caring about you, the correlation is fairly strong, but it's similar for each of the items, 0.6 essentially, between these different behaviors and the overall global rating of satisfaction. And of course, all these correlations were highly significant. These 2 that are highlighted here in red, in terms of their explaining the amount of variance in the data set, these 2 items seem to explain more of the variance than the others. So answering all your questions about illness and treatment, and this item that says caring about you as a person, which seems intuitively important to do, but hard to specify how to operationalize that in very specific ways. The other items, 7 to 13, where I said there were a lot of didn't do responses, I think we had a harder time assessing these correlations. I think partly the issue is there's so much missing data that didn't do responses. It made it harder to calculate correlation coefficients. And so the correlations were not as strong, but I think there were some limitations in terms of what we could deduce from these items and their correlation with overall satisfaction. The other thing that Amani did in her thesis work was just to do some linear regression modeling after excluding the items that had a lot of didn't do responses, to look to see how much of the variance do all of the items together, items 1 to 8 plus item 11, how much do they explain the overall variance? And it explains about 50% of the variance in the data set. And so it seems like these, if I go back to the detailed items, that these items 1 to 6, the behavior ones, the generic communication skills behaviors, and maybe this number 11, involving you in decisions, if you get too sick to speak for yourself, that those explain about half of the variance in the data set. We didn't find any other significant explanatory factors such as age, patient factors such as age or gender. And so the qualitative data we thought might be helpful because, as I said earlier, a lot of those generic communication skills behavior were all sort of equally correlated with the global rating of satisfaction and didn't really point to particular behaviors that were especially important. And so we thought the qualitative data may help to flesh this out by drilling down and doing a deeper dive into this phenomenon, and also just might enrich what we can learn just from the quantitative data itself. So I will move now to a summary of the qualitative findings from the study. So remember that these were semi-structured interviews with a much smaller sample of 16 seriously ill patients, which is a modest size for a qualitative study. And I think we were reaching reasonable saturation, but I would just highlight that, that this was a sample size of 16. The qualitative themes that came through the analysis of the transcripts using an interpretive description approach were the ones listed here on the slide, which Amani has labeled as nonverbal behaviors. A second one called Knowing Me, which is really around person and family-centered care. And a final one, which to me was the most interesting one, and perhaps maybe novel one, but certainly most interesting, was this notion of conditional candor, and I'll explain that a bit more when I go through each of these in more detail. So the first one was theme was called nonverbal behaviors, and the sub-themes there were expressions of personal connection with the patient and this notion of being present. So not just physically present, obviously, but the notion of being present in the moment with the patient. So here are some illustrative quotes. I won't read them out, but you can see them there. I hope that I've never dreamt up what I was going to have for dinner when talking to a patient, but we do get sometimes distracted. So just to flesh this out a bit more, patients, this is in the greater theme of nonverbal behaviors, participants expressing this desire for a personal connection, and how can that be done in nonverbal ways. And here's some quotes here that illustrate it. So clinical, no warmth, and didn't think that was a good approach for me. And this notion of being present in your nonverbal behaviors. So being present for the moment, even if it's a busy day, but I'd like a bedside visit, even if it's only 3 or 4 minutes. I guess what the patient is saying, if the person can spend the time and be there in the moment, it can still be helpful. And then this notion of showing full attention and again being present in body language. And they do say that 60, 70, 75% of communication is in fact nonverbal. The second major theme was this notion of knowing me, which to me was a less surprising finding. I won't delve into it in a lot of detail, but just this notion of trying to understand the person, the patient as a person, as well as a person who resides within a family context. And when I say family, I mean blood relatives and friends. And so here are just some quotes that illustrate that. But I think this just reinforces the notion of patient and family-centered care that is an important tenet of a palliative approach to care. So this last theme, which I found interesting, was this theme that Amani labeled as conditional candor. And the sub-themes here being assessing readiness, receiving an invitation, and appropriate delivery of information. And so this theme, I think, really, sorry, I'll go back to the slide. I think it speaks to the tension between trying to be honest and provide transparent information, which patients consistently ask for, but also meeting patients and families where they are in terms of how ready they are emotionally to receive this kind of information. And so here's some of the quotes from the study. So in terms of assessing readiness, the notion that even within a single patient that their level of readiness can fluctuate over time. And I think emphasizing the issue of being attuned to how ready patients are and even asking directly where they are at in terms of their ability to engage in these conversations. And the notion that advanced care planning or end-of-life conversations are more of a process than a single discussion because readiness may change over time. And so to my earlier point, this notion of just obtaining permission and checking in with patients to see how ready they are to embark on this discussion, and if not, what is it that might be preventing them from engaging? Another issue around obtaining permission is trying to understand, well, in how much detail do they want to hear about things if they are around prognosis? And are there other people that they would like involved in the conversations? And so there's the tension of, the readiness issue versus patients being pretty clear about wanting honest, candid information and not having information hidden from them, and yet while being honest to do it in a sensitive manner. And this particular patient relaying an experience where they felt that the communication was not so sensitive. I think the quote at the very bottom of this slide is a more stark example of perhaps not the greatest approach to broaching an end-of-life discussion. So someone came through the door, kind of woke me up and yelled, "I need an answer, yes or no." I said, "I'm sorry, I'm not in a position right now to make a decision." And she said, "Well, I just have to know yes or no." Some illustrative quotes to outline this theme of conditional candor. And so how did, when we got to the mixed method stage and comparing and contrasting the quantitative results with the qualitative results, how did we sort of make sense of this and put this together? I think the qualitative data helped to flesh out, some of the items that were identified as correlating highly with global satisfaction, like listening what you have to say and giving full attention. The qualitative data helped to flesh out some of the things that might be behind those quantitative findings. This notion of nonverbal behaviors and being present in the moment and mindful, and the attentiveness to patients' levels of readiness to engage in these conversations. One of the issues is that in the qualitative data, it was perhaps easier to pick out some prominent themes that stood out in terms of priority behaviors, whereas in the quantitative data, it was really hard to say that one particular behavior was perhaps more important than others. And so, just to wrap this up so that we can have a good amount of time for questions and answers, what did we feel were some of the implications for practice and future research after conducting this study? So I think for me, the most important reminder was that physicians need to be attentive to differences between patients or even within a given patient around their readiness to engage in end-of-life conversations. And speaking to the fact that this requires an iterative process, not a single conversation, appropriate titration of information to their level of readiness, and a sensitive approach. And that's not to say that if patients aren't ready, you should abandon all conversation, but that if they appear to not be ready, to then shift the conversation to explore what might be some of the barriers or to address perhaps emotional issues that are preventing them from engaging further. For example, exploring what are their fears, what are their concerns, rather than going straight to perhaps conversations that are centered on prognosis and values and treatment preferences. We hope that these findings can be somewhat helpful for people who are designing educational programs or interventions around communication skills training, because it highlights certain issues that patients find helpful and important when engaging in these conversations. And one of the things we did learn, and I didn't get into too much detail because of time constraints, but when we were going through our quantitative analyses, we did find that there were perhaps some limitations to the quality of communication tool, and that more work could be done to further refine that tool. Finally, because of the importance, this important theme that emerged in the qualitative data around patient readiness, developing validated tools to screen patients for readiness to engage in these conversations might be a useful sort of research activity. And in fact, we have collaborated with Rebecca Sador, who's an advanced care planning expert in California, to develop a number of different instruments, sort of longer ones and short screening versions, to assess readiness to engage in advanced care planning. So that is sort of the end of the didactic part of the webinar. It looks like we have a good 15 or almost 20 minutes for questions and answers. And so I will, I think the easiest way to do this is to turn the floor over back to Carol and the CFN leadership team to sort of help field questions. Thank you very much.
Thank you, John, for your excellent presentation. We do have a few questions. I think there might be more questions than we can do, but we'll try to get through them. So one of the first questions that I have, and it's sort of maybe after this, what is the impact? Because one of the questions is, after the end of life initial conversation that happens in a clinical setting, is there a website where these citizens or their caregivers can go to get more information when they leave that healthcare setting, so that they're in their own home and they're able to at their leisure go through what does all of this mean, and then be able to get back to you on further follow-up?
Yeah, it's a great question. I think we have this challenge where healthcare is so fragmented and siloed across a number of different settings. And so, for example, this study was really looking at hospitalized patients, but of course these patients are, most of them will be discharged and will move through a number of care settings in the rest of through the rest of their life. And so it's the challenge of, because these communications are an iterative process and not a single conversation, how can we have what a colleague of mine calls a single source of truth that would document in the health system for providers, where is the patient at in terms of these conversations and any decisions they might have made around end-of-life care, so that as they travel through the system, the providers can have access to what's been discussed to make decision-making and provision of care more efficient, and to make sure it aligns with patients' values and preferences. And so I would say that this achieving the single source of truth in the electronic health record to document these important pieces of information, that's still a holy grail that we are seeking, and I'm not aware of any jurisdiction that has quite perfected this. Although, interestingly, in Alberta, they do have a provincial policy and initiative around documenting advanced care planning and goals of care designation using consistent documentation across the province, and having that document reside in what's called a green sleeve that can be taken across settings as a visible kind of place where this stuff can be documented. So that's the first half of my response, because I think there was a second part to that question about resources for patients and families when they're maybe at more leisure after the hospital stay, to maybe continue on some of these discussions or start some of these conversations that may have only been initiated or suggested in hospital. And I guess since we're in Canada, I think I would point to the Speak Up website That's the Canadian Hospice Palliative Care Advanced Care Planning Initiative. And the Speak Up website has links to resources that can help patients and families start these conversations around advanced care planning and give them a way to document some of that. And they do have guides and tools that are even tailored to different jurisdictions in Canada. So for example, for those of you on the line who are in Ontario, there is an Ontario-specific advanced care planning guide that fits with our legislative context. I think there's also a BC-specific guide, and there are paper-based and web-based formats. So I would recommend the Speak Up stuff as a good place to go to, since it's a Made in Canada resource.
Yeah, I've seen that, and it is a great resource. And just to further on your point, John, about I was at a conference and I did see that green sleeve or duotang, but it's not in electronic format yet, is it?
As far as I'm aware, no. The green sleeve is a paper thing. And I guess when I was talking about the single source of truth, what I would love to see at some point is, but it requires a universal health record, which we have not been able to solve in Canada yet. But if we had a single spot in the electronic medical record that was highly visible and that had, advanced care plan, and that clinicians could see that, and it could be updated by anyone after any encounter in the system, that would be very helpful. But I don't know of any jurisdiction that has achieved that.
Yeah, I think you're right. We still have a lot of work to do, I think. Now, we did get, it's not really a question, but it might be just information. It says Quebec now has a ACP database, but I'm not sure what that database is. Do you have any information on that? Is it a website or?
So I don't know in detail. One of our study sites in our hospital-based program of research is in Montreal, and my Montreal site lead, his name is Dr. Jayaraman. He's an internist and critical care physician at McGill at Montreal General. He did tell me about there being a sort of a shared electronic health record across some of the hospitals in their system. So I'm a little bit ignorant because I don't work in Quebec, and so I don't know the granular details, but I think there is a spot within their network of hospitals where levels of care forms can be documented. So that would be leaning more towards like specific code status type decisions, as opposed to, I was also referring to more broader advanced care planning values and goals types of discussions. But I think there is some infrastructure in Quebec, yes.
Yeah, I see that she's also added a website here, and so maybe we could share that later.
Yeah, that'd be terrific. I certainly don't know about all the different things that different systems are doing in Canada.
Yeah, the unfortunate part is there's so many different legal interpretations across the provinces and territories, and we'll eventually solve that, but it does get a little difficult for people to try and go to one place and figure out what they can do. And even as a a caregiver, looking at how to bring up those questions, and after you come home from that setting of care. Another question that came about, I think they're coming in quite fast and furious here, so I keep losing my spot here. There was one from a question from Community Health at University of Laval, a PhD student, I believe. She has an ethical question about the need to present all life-sustaining interventions in an advanced care planning discussion or goals of care discussions in hospital, even if the patient is clearly dying or has advanced disease, and what not benefit from these interventions.
Yeah, so that's an easy one. So well, I guess we've been working locally at my hospital site, Hamilton General. We're just about to launch an implementation project, sort of a quality improvement initiative and a pilot project at the same time. to implement what's called the Serious Illness Conversation Guide, or the Serious Illness Care Program, which was developed by colleagues at Harvard, Susan Block and Atul Gawande. And really one of the main tenets, or the premise behind the Serious Illness Conversation Guide, is that in fact these conversations shouldn't begin with choices about treatments, which is, I think, as a physician, a mistake that I often still make and routinely made when I started practice. So the questions shouldn't be, do you want, CPR or ICU admission or X, Y, or Z? But really, the conversations should be, what do you understand about your illness right now? Talk about what the patient's prognosis is in an honest and sensitive way, and then ask the patient about, as a person, as time is running short for them, what's most important to you now? What are your most important life goals? What kinds of abilities would you not want to lose? What kind of trade-offs would you be willing to make? Like, how much suffering are you willing to go through for the sake of getting more time? What are you afraid of as time is getting short? And none of those questions that I just described, and none of the discussion points that I just described have any specific language around, do you want treatment X or Y? And the beauty of this approach is that 9 times out of 10, now there will be situations of conflict, I think, between healthcare teams and patients and families, which I think is what the question is alluding to, and I'll get to that in a sec. But 9 times out of 10, after you have that kind of a conversation with patients and families, it then puts you as a clinician in the position of being able to make recommendations about treatment that are in line with patients' values and preferences and goals, as opposed to asking a menu of choices. And that's where, in a shared decision-making approach, the clinician brings their expertise in terms of what's medically reasonable and possible to achieve the sorts of goals that the patient has just articulated. And so my take on all of this is that as clinicians, we need to be comfortable making recommendations, but not in a vacuum, and not recommendations based on our own values, but make recommendations that are based on the patient's values. And so there certainly would be situations where I wouldn't even table certain interventions if I didn't think that they were medically reasonable and were not in line with patients' values and preferences. So that is, I think, the key point that I wanted to make. Now, the issue of, is it ethical to not offer certain treatment options, I think that's what the question was speaking to, in the situation where we think that treatment is futile. From an ethical or moral point of view, I personally, as a clinician, I don't think we should be offering treatments we believe are going to be non-beneficial. In terms of what's legally required, I'm not a legal expert, but I can tell you in the Ontario context, there have been legal challenges to the issue of not offering treatments such as CPR, and it's been challenged, and the College of Physicians in Ontario has had to revise their policy to essentially state that even if a physician believes that CPR would not be beneficial, if the patients or families insist, then you can't just unilaterally write a DNR order, for instance. And you have to still discuss it and seek a conflict resolution process, but you can't unilaterally just not offer something. But to be honest, I think those situations are fairly uncommon, and I think the biggest mistake that we make is that we don't start with patients' values and goals and then move to recommendations and try to align treatment with goals. So that's my short answer to that question.
That's a difficult question. So here's another interesting question. I think you kind of alluded to this during your presentation, but she was wondering how you can address the time-limited context in the ICU where patients need to make more urgent decisions.
Yeah, it's a challenge. When crap hits the fan and patient's status is changing by the minute, then you just have to deal with those constraints, but it speaks to the value of having more proactive, preemptive, upstream conversations about advanced care planning and goals of care discussions, so that, you know, usually it's the family, the substitute decision maker, that you're having to interact with as a clinician in those circumstances. And to the extent that the substitute has engaged in good advanced care planning and knows what the patient's values are, knows what the patient, you know, would want in terms of not treatment, but of what kind of outcomes would be acceptable to them, then you can have a more effective conversation with this substitute about, well, given what we know about what you've told me about your loved one, I suggest we do X or Y. But in the absence of those upstream conversations, then you're kind of stuck and have to do the best you can. I don't have anything better to say. I don't think, other than it's a challenge. Now, I don't work in critical care, so I don't have a lot of pearls for the ICU setting. I work in on a general medical floor, so we have the luxury of a little bit more time usually. I mean, the one thing I would say though is that sometimes people tell me, and it sounds a bit of an excuse, oh, well, I don't know these patients, I have no previous relationship, why am I, and they're expressing frustration that they're in the position of having to have these conversations with patients and families. But I think it's entirely feasible to build rapport with patients and families very, very quickly if you've had experience doing it. So the time is certainly a constraint and pressure, and it doesn't make things ideal, but proactive conversations can help.
Okay. One last question, and probably then we'll have to end after that, is what things can we do to make sure good end-of-life communication never happens?
Is that a question for me, or?
That's a question for you.
Yeah, that was one of our icebreaker questions.
That was, yeah, I think there's a few questions that have come in that context, and that kind of summarizes 3 or 4 questions on the board.
Yeah. What can we do to make sure this never happens? So we've used this as an icebreaker question in other meetings just to get things going. Well, you know, I'm a physician. I guess one answer would be leave it all up to the doctors to do it. Would be one thing. I don't know.
And that's kind of a good answer, John, because one of the questions actually said is, did you have a sense that when physicians were not strongly involved in end-of-life communication, that other clinicians such as nurses took a more active role?
Well, we didn't directly look at that in this study. I think what we have found in other work is that you know, that nurses are clearly playing an important role in having goals of care conversations. But it's not, and I'm speaking from a physician lens, I think certainly as physicians, and then maybe even as in the system more broadly, the role that nurses are currently playing is under-recognized and undervalued, and yet informally nurses have a lot of sometimes direct or sometimes indirect subtle conversations with patients and families to start broaching goals of care discussions. But we've also found in other work that the nurses, and I'm speaking of hospital-based nurses, don't necessarily feel all that supported. They don't feel unsupported, but they don't feel particularly supported in their work environment to engage in these conversations. And at the same time, many of them are willing to, and other members of the care team, including physicians, would find it acceptable for nurses or other professions to engage in, and at least some parts of these conversations. There may be certain parts that are maybe best suited for the physician, like talking about prognosis, but the range of issues around discussing values and fears and concerns and trade-offs, those are issues that anybody on the team can engage with. So, yeah, maybe that's a good place to end, is to say that I think there's certainly an opportunity to think about a much more interprofessional approach to having these conversations as opposed to it being just on the shoulders of the doctors.
Yeah, that is a good, I think there's been a lot of questions on how can other health professionals do more and be more engaged. So I think that's something that there's maybe some more work to do in that area. And thank you, John, for very good Q&A and presentation. I think there'll be some questions that aren't answered, and we'll see if we can get to some of them. But just to end, as I know people are trying to get back to work, there is a brief survey that will come up on your screen that you can give some feedback. There's some open-ended questions, yes or no, or there's some place where you can make comments. And just to look on your screen, here's some upcoming webinars, and hopefully you'll register and we'll see you on the next one. And again, on the slide, that's the website where you'll find the webinar and the PowerPoints. So thanks for joining us today, and thank you again, John, and hope everyone has a wonderful day. That's it for today.